Part 2, COVID-19 Post-Discharge Recovery, Progression, and Infection Control in the Outpatient Setting. Disclaimer: this course is intended for educational purposes and does not replace mentorship or consultation with more experienced cardiopulmonary or acute care colleagues. This content is current at time of dissemination, however, realize that evidence and science on COVID-19 is evolving rapidly and information is subject to change. My name is Jessica Riggs Garton, and I am a board-certified orthopedic specialist and certified lymphedema therapist. I received my Bachelor of Science in Computer Engineering in 2001 from Brown University and worked in computer chip design for 4 years before changing careers. I received my Doctor of Physical Therapy from the MGH Institute of Health Professions in 2008, and I have been an orthopedic clinical specialist since 2014 and a certified lymphedema therapist since 2014. I currently work full-time at Mass General Hospital Outpatient Physical Therapy in Boston, Massachusetts since 2008, where I treat a variety of patients, the populations ranging from orthopedic, oncology, and cardiopulmonary. I work as a physical therapist in the MGH Pulmonary Rehabilitation Program, and I also work individually with patients with a variety of pulmonary conditions. Since 2015, I have been working as part of the interdisciplinary team at the MGH for Children Pediatric Cystic Fibrosis Clinic. I've been a member of the APTA's Cardiovascular and Pulmonary section from 2011 to 2020, and I have no disclosures related to this topic. The objectives are to describe post-acute care considerations and disposition for patients hospitalized with COVID-19, and to discuss proper screening and infection control in the outpatient setting as it relates to COVID-19. Due to infection control measures, many patients will not have ambulated outside their room prior to discharge from the acute setting. Depending on continued oxygen needs, patients who are hemodynamically stable may be discharged on supplemental oxygen and may continue to require supplemental oxygen during outpatient physical therapy. Patients will be evaluated by the acute care team, including physical therapy, to determine the best discharge disposition. This could be home, a skilled nursing facility or rehab, outpatient PT, or perhaps no services are needed. Factors to consider at discharge from an inpatient hospital stay: the layout and accessibility of the patient's home, any support available to the patient in terms of family or friends, and their ability to self-quarantine if they're still COVID positive. There are additional problems and concerns that may arise after discharge, and the outpatient physical therapist needs to be aware for and screen for this. There are different locations that one can be discharged from after their acute care stay. A hotel or field hospital. Patients who are safe to return home but cannot self-quarantine will likely be discharged to a setting outside the home. This can include a local hotel or field hospital until they test negative for COVID-19. If they're discharged to a hotel setting, they will likely have done minimal activity during their stay, as they are isolated to that room only. A rehab facility or field hospital. Patients who are not safe to return home will be discharged to a rehab facility or field hospital. Upon discharge from the hospital, patients may still be unable to get in and out of bed, walk household distances, or traverse stairs independently. Physical therapy and occupational therapy will be available to assess and progress patients in this setting until they are safe to return home. Home health PT services. Patients who are able to return home with assistance from family members will be sent home with physical therapy services, where the physical therapist will come into the home and work on improving their mobility. Outpatient PT referral. Patients who can return home without the need of services but are still below their baseline level of function may get a referral for outpatient PT upon discharge from the hospital. In a rehab or field hospital setting, physical therapy will be working on any of the following based on patient presentation. These may need to be carried over to outpatient physical therapy or home health PT. Improving breathing mechanics, progressive strengthening of upper body, lower body, and core muscles, endurance training and weaning from oxygen, safety and balance. A few days prior to their scheduled appointment in an outpatient setting, patients should be called and screened for symptoms of and exposure to COVID-19. Patients who answer yes to any of these questions should be referred for COVID testing, and their appointment in outpatient PT should be delayed pending results. These symptoms include fever, cough, shortness of breath, chills, muscle pain, headache, a new loss of smell, sore throat, or they've been in contact with someone who has tested positive for COVID-19. Upon arrival and check-in, advise patients and visitors entering the facility, regardless of symptoms, to put on a cloth face covering or face mask before entering the building and await screening for fever and symptoms of COVID-19. Consider having patient screening outside of your department to limit the amount of people who enter who may be positive. Triage personnel should have a supply of face masks or cloth face coverings. These should be provided to all patients who are not wearing their own face covering at check-in, assuming a sufficient supply exists. Ensure that at the time of patient check-in, all patients are asked about the presence of fever, symptoms of COVID-19, or contact with patients with possible COVID-19. Post signs and posters, like the link provided here, at the entrance and in strategic places, including waiting areas, elevators, cafeterias, to provide instructions in appropriate languages about hand hygiene and respiratory hygiene and cough etiquette. Instructions should include wearing a cloth face covering or face mask for source control and how and when to perform hand hygiene. Make sure you provide supplies for respiratory hygiene and cough etiquette, including alcohol-based hand rub with 60 to 95% alcohol, tissues, and no-touch receptacles for disposal. This should be located at healthcare facility entrances, waiting rooms, and patient check-ins. Install physical barriers, either glass or plastic windows, at reception areas to limit close contact between triage personnel and potentially infectious patients. Make sure to isolate patients with symptoms of COVID-19 in an examination room with the door closed. If an examination room is not readily available, ensure the patient is not allowed to wait among other patients seeking care. In terms of the waiting room, a separate, well-ventilated space should be identified that allows waiting patients to be separated by 6 or more feet with easy access to respiratory hygiene supplies. In some settings, patients may opt to wait in a personal vehicle or outside the healthcare facility where they can be contacted by mobile phone when it is their turn to be evaluated. A reminder about hand hygiene. Healthcare providers should always perform hand hygiene before and after all patient contact with potentially infectious material, and before putting on and removing PPE, including gloves. Hand hygiene after removing PPE is particularly important to remove any pathogens that might have been transferred to bare hands during the removal process. Healthcare providers should perform hand hygiene by using the same alcohol-based hand rub or washing hands with soap and water for at least 20 seconds. If hands are visibly soiled, use soap and water before returning to an alcohol-based hand rub. Healthcare facilities should ensure that hand hygiene supplies are readily available to all personnel in every location. A reminder about environment of care. Ensure that environmental cleaning and disinfectant procedures are followed consistently and correctly, and that all surface areas and equipment are properly cleaned in between patients. This may require additional personnel to be vigilant. Some workplace considerations to avoid employee exposure. Eat and drink away from others. When infected, an individual can be contagious starting 2 days before symptoms begin. When employees take masks off to eat and drink together without maintaining a distance of 6 feet, exposures can result. Manage break room to reduce crowding. If social distance in break rooms cannot be maintained, consider finding alternate areas to take breaks or staggering break times. Keep your distance when possible. Do your best to maintain 6 feet of separation from coworkers when your work permits. Sometimes our work requires us to be within 6 feet of one another. This is fine as long as everyone wears a mask. Avoid crowding when possible. Minimize crowding together in conference rooms, break rooms, and other places where people tend to cluster. Wear your mask correctly. Ensure that your mask is covering both your mouth and your nose at all times. Apply your mask with clean hands. Avoid touching it, and if you do touch it, clean your hands immediately. Remove the mask from behind, avoiding touching the front. In order to limit potential exposure, the following are considerations for the outpatient workspace. Limiting the number of patients seen in a given hour to reduce crowding in common spaces like the waiting room and gym areas. This may require extended clinic hours to treat the same number of patients in any given day. Appropriate distancing for staff in areas during break and lunch, at least 6 feet when masks need to be removed for eating and drinking. This may require some creative use of space or even shifting of staff hours so that breaks don't occur at the same time. Here's the link to the CDC guidelines for ambulatory care settings with regards to the coronavirus.